Hello, everybody. Welcome for today's webinar conducted by CPOM Foundation. The webinar is about what is new in locally advanced and metastatic pancreatic cancer. We have two esteemed speakers with us today. One, Dr. Sharlene Gill, who will deliver the keynote session, followed by a panel discussion where the expert panelists will discuss two cases presented by DM trainees or oncology fellows. We also have Dr. Anant Ramaswamy, who is a senior consultant, GI medical oncologist in Tata Memorial Hospital, Mumbai. We thank the sponsors of the meeting, Zydus Pharma and Fresenius Kabi. I'll introduce Dr. Sharlene Gill initially. Dr. Sharlene Gill is a renowned medical oncologist specializing in gastrointestinal malignancies from British Columbia Cancer Center at Vancouver. Her training is mainly from Mayo Clinic in Rochester, Minnesota. She's also done a MPH from Harvard Public School and an MBA from University of North Carolina. She's a professor of medicine in the University of British Columbia at present, and she has significant expertise in colorectal, pancreatic, and hepatobiliary cancers. We also have Dr. Anant Ramaswamy, who is a very senior consultant GI medical oncologist at Tata Memorial Hospital. He has done his fellowship at Tata Memorial Hospital and the initial training at KGMC Lucknow and Armed Forces Medical College at Pune. He is very well known in the academic circles and has multiple grants and peer-reviewed publications to his credit. Few housekeeping announcements. Please ensure that internet connectivity is good to have a seamless experience. By default, all the attendees will be in mute and listen-only mode. Attendees can also choose to ask questions by typing in the question and answer section. This session will be recorded. Now I request Dr. Sharlene to deliver her presentation.
Well, thank you very much for the kind introduction, and I'm happy to speak to all of you tonight about advanced pancreatic cancer. These are my relevant disclosures for this presentation. So, in the next 30 minutes or so, I'm going to just very sort of introduce the topic in terms of discussing the epidemiology of pancreatic cancer, the scope of the problem, review current standards of care, and with kind of a precision oncology lens, focus on what probably are the more near immediate, potentially actionable biomarkers in advanced pancreatic ductal adenocarcinoma. And so I'm going to kind of review the data around DDR, DNA damage response, and specifically BRCA and KRAS G12C. So, at a global level, we all recognize that pancreatic cancer is a problem. It represents, probably the 12th most common malignancy among adults, almost half a million cases per year, and is typically within the top 4 or 5 leading causes of cancer-related mortality. In my country, in Canada, typically the incidence almost equals the mortality. So the number of new cases very closely approximates the number of deaths per year with pancreatic cancer. And I think this is not unique to Canada. It's reflective of the really high lethality associated with pancreatic cancer. Fundamentally, we think about carcinogenesis as a combination of sort of genetic and acquired factors. Pancreatic cancers, the pathogenesis of pancreatic cancer has been described well in terms of a sequence of genetic alterations that typically are associated with early activating mutations in proto-oncogenes, such as KRAS, which is very commonly seen in pancreatic cancer, and later inactivation of tumor suppressor genes. And that pathogenesis pathway kind of has been described as a sort of a multi-step progression model arising from pancreatic intraepithelial neoplasia to outright invasive malignancy, and again, landmarked by these sort of chromosomal genetic mutations over time. When we think about sort of the etiology of pancreatic cancer in the patients that we see, probably almost half or 40% are truly deemed to be sporadic in nature. Others may be associated with either inherited or acquired risk factors. It's believed that about a third of pancreatic cancers can be related to smoking. So again, the importance of smoking cessation programs and mitigation for pancreatic cancer and prevention. Lifestyle and dietary factors are also implicated, and less than 10% are truly inherited in nature. As I mentioned earlier, smoking probably represents the biggest demonstrated sort of lifestyle risk factor associated with pancreatic cancer, but we also know that there is an association with high body mass index, heavy alcohol use, a history of pancreatitis. In terms of genetic factors, while a family history is seen in approximately 1/5 of patients, true inherited syndromes are less common. We define a familial pancreatic cancer as a cancer that is present within a family in 2 or more first-degree relatives. And individuals with a family history, even with one first-degree relative, have an increased risk compared to the average risk in the population. And that can be, depending on the study and the number of family members involved, anywhere from a 2-fold to a 13-fold increase. The germline mutations that recognized with familial pancreatic cancer, probably the most common and the one we're going to talk about a lot, is BRCA. But we also see with PALB2 mutations within that DDR family. Other hereditary pancreatic cancer syndromes to think about, I think, for those of us who treat other GI cancers as well, Lynch syndrome, which is associated with deficiency in DNA mismatch repair, and pancreatic cancer is a part of that. Hereditary breast ovarian cancer, FAM or familial atypical mole melanoma, hereditary pancreatitis, and Peutz-Jeghers syndrome. So really kind of switching gear here and talking about the treatment of advanced pancreatic cancer, which is kind of our focus for this evening. In the landscape of pancreatic cancer, sort of dating from the late 1990s to the first decade of the 2000s, after the initial, from many years ago, back in 1997, the study of gemcitabine versus 5-FU, which established gemcitabine as a standard of care in the first-line setting. Many of us who are old enough recall a series of negative trials trying to look at various cytotoxic combinations partnered with gemcitabine that failed to demonstrate any improvement in overall survival. And it really wasn't until about 10 years ago where we had data that changed our current first-line standard, looking at FOLFIRINOX from the ACCORD trial and gemcitabine nab-paclitaxel from the IMPACT trial, both in the first-line setting in chemo-naive patients with advanced pancreatic ductal adenocarcinoma, demonstrating a survival benefit. And at the time these studies were reported, there was a lot of sort of debate back and forth. Is there a better regimen? The data for ACCORD 11 with FOLFIRINOX demonstrated a median survival, these numbers are incorrect, of 11.1 months versus about 6 months, versus gemcitabine nab-paclitaxel, where it was 8.7 months versus 6.6 months. But we also recognize that the gem nab-paclitaxel study included a slightly different profile of patients with some included patients with a performance status of 2, KPS 60. And over time, I think we've recognized that it's a bit of a dealer's choice in terms of first-line treatment choice. My preference is still FOLFIRINOX in patients who are suitable for FOLFIRINOX, but for those patients where the toxicity of FOLFIRINOX may be significant, I think gemcitabine nab-paclitaxel is recognized to be a first-line treatment standard. So, why has pancreatic cancer been such a difficult disease site to make significant progress in? And I think it's recognized that the tumor biology in pancreatic cancer is challenging. So we talked earlier about, inactivation of multiple tumor suppressor genes, and typically these have been non-druggable tumors, aberrations. Few predictive biomarkers. We're going to talk a little bit about a few emerging biomarkers that may be promising. Inherent drug resistance, and a big one in pancreatic cancer is sort of the complex tumor microenvironment. And a number of approaches have tried to focus on targeting the tumor microenvironment and the tumor stroma. And so, when we think about, the potential opportunities in pancreatic cancer, targeting cancer cell pathways and the tumor microenvironment, I think that this gives us a lot of promise. The reality, however, is that many of these targets in recent years, so these represent studies that have been reported within the last 3 years, have unfortunately been disappointing. So I feel like we're kind of entering a loop again of the era in which we were trying to look at different cytotoxics, where combining a first-line chemotherapy regimen with a novel targeted agent has not yet yielded, a meaningful improvement in these various studies. So Resolve was a first-line study of gemcitabine nab-paclitaxel plus or minus ibrutinib, so a BTK, a Bruton tyrosine kinase inhibitor, where the overall survival, in fact, looked a little bit better in the control arm. HALO was a trial of chemo plus or minus pegylated hyaluronidase, again focusing on the tumor stroma. No significant improvement in survival, despite encouraging sort of phase 2 data that led into the phase 3. Napabucasin is an inhibitor of cancer cell stemness. And so a phase 3 trial of nab-paclitaxel plus napabucasin was reported in a press release, also to not reach that primary endpoint, no difference in overall survival. Avenger is a trial of modified FOLFIRINOX with devimistat. Even immunotherapy, if we think about gemcitabine nab-paclitaxel plus or minus a PD-1 or CTLA-4, PA7 was a randomized phase 2 trying to look at that immunotherapy combination in the frontline setting. The intent was, if this randomized phase 2 was positive, it would go on to a phase 3 trial. But unfortunately, at the phase 2 analysis, the survival efficacy parameters were not met to go on to a phase 3. And like in the second line setting, I think more recently we've heard of data from Sequoia with peglodecan in combination with second line FOLFOX, and was presented at ASCO GI, Tribeca, chemo plus aerospace, which is an L-asparaginase, also in the second line setting, no improvement in combination with chemotherapy. So this is, discouraging a huge amount of effort and patient involvement to get these trials done, which is always important. And these trials have all managed to accrue within their target. So we know that there is a really huge appetite amongst patients to be able to participate in these trials, but unfortunately, nothing that has yielded a change in standard of care. Where there have been some inroads has been looking at BRCA and related mutations in DNA damage response and repair. So DDR mutations in pancreatic cancer are estimated to be seen maybe in about up to 25% of patients. These include homologous recombination DNA damage response mutations. So we commonly talk about BRCA1 and 2, but also ATM, PLB2, and less common ones, as described here. We know, before thinking about sort of a targeted approach back to sort of chemo fundamentals, we know that deficiencies in DNA damage response do predict platinum sensitivity. And this was data published at ASCO GI a couple of years ago, which demonstrated that in patients with resected disease, the absence of DDR deficiency didn't suggest absence of benefit from platinum-containing therapy. So in that adjuvant setting, it seemed that was less important, I guess, as a predictive factor for platinum response. But in the advanced setting, DNA damage response is a very strong predictor for platinum sensitivity and is associated with an improved survival. BRCA1/2 mutations in pancreatic cancer specifically are believed to be observed in 5 to 7% of patients with pancreatic cancer. They are implicated, as I said earlier, in hereditary syndromes like familial pancreatic cancer and familial breast ovarian cancer. And among patients who have an Ashkenazi Jewish heritage, I think the prevalence we recognize of BRCA mutations is higher. It's important to remember that we shouldn't only consider testing in patients who have a family history. So it's estimated that maybe 40% of patients who are found to have evidence of a germline BRCA1/2 mutation do not have a reported family history of breast or ovarian cancer. And so for that reason, and we'll talk about it again later, but we recommend testing in all patients with pancreatic cancer. From a treatment perspective, how does this inform our treatment beyond the platinum sensitivity? Well, we know that PARP inhibitors are a class of drugs that can be exploited in BRCA mutated disease. And so this data from the POLO trial looking at maintenance olaparib for germline BRCA mutated metastatic pancreatic cancer is a noteworthy trial to consider in this population. Again, published now almost 2.5 years ago. And as I mentioned earlier, we think that about less than 7% of patients will harbor a BRCA mutation. We know about the increased benefit from platinum-based chemotherapy. And we also recognize that within the current standard of care, if we think about FOLFIRINOX or gem/nab-paclitaxel, as I discussed earlier, there's obviously a huge unmet need. Our median overall survival, even with FOLFIRINOX, is still less than a year. So at the time POLO was reported, this was presented at ASCO plenary as well. It was important because at that time we had yet to have a sort of a validated a biomarker, a validated phase 3 trial in this space. And POLO enrolled patients with metastatic pancreatic cancer, confirmed BRCA1/2 mutation, who had evidence of disease control. So no progression after 4 months or 16 weeks of upfront platinum-based chemotherapy. So excluding patients whose response was primary progression. And in fact, surprisingly, about 38% of patients had evidence of disease progression at 4 months. I say surprisingly because this was primarily platinum-based upfront chemotherapy, as well as patients who elected after initial enrollment to decline randomization. At that point, patients were randomized in a 3-to-2 fashion to receive olaparib versus placebo. And the primary endpoint was progression-free survival. Over 3,300 patients were screened to identify 247 potentially eligible patients. Again, that's 7% prevalence. After initial exclusion, the trial enrolled in 154 patients. And POLO was positive for its primary endpoint of progression-free survival, 7.4 months versus 3.8 months with placebo in this patient population. Objective responses were also higher during that time on maintenance olaparib, 23% versus 11%. The median time to onset of response was actually a bit late, but the duration of response was more durable with olaparib. Even though this was offering patients a chemotherapy-free interval, there was no reported sort of quality of life differences with olaparib versus placebo in either direction, sort of in terms of either a detriment or an improvement in that maintenance phase. And then more recently, this year, the final overall survival data was reported for POLO. At the time it was initially presented, there was interim overall survival. This was a secondary endpoint, but obviously in pancreatic cancer, a really important endpoint, probably the one that we think would be clinically most meaningful. And in its final overall survival there was no difference seen in median overall survival. We do see that the 19 months compares favorably to what we think about in this population, but again, I think that may be driven by the platinum sensitivity in this group. And so, where do we go with that information? So I think POLO represents a valuable contribution, as I said, as the first successfully completed biomarker-driven trial in pancreatic ductal adenocarcinoma. You could argue is coming off chemotherapy and going to placebo truly a standard of care? I think in our practice, most of us would say if we have patients with non-progressive disease after 4 months of chemotherapy, we would carry on the treatment. Typically, we use a treatment, to treatment failure type approach with our first-line chemotherapy. And this is, did this change my practice? It really didn't. In Canada, in fact, because of the absence of an overall survival benefit, this is not something that is a funded therapy for my patients with pancreatic cancer. And I'm not sure it should be. If 7 months, that 7 months progression-free survival, as was discussed when this data was first presented, could cost at market list prices for olaparib over $125,000. Is that value in the absence of an overall survival benefit? I think is an important question. However, I do still believe that upfront BRCA testing is important in our patients with advanced pancreatic cancer, both for hereditary ascertainment and predictive assessment, especially with platinum sensitivity, because sometimes we are in a situation where we're thinking FOLFIRINOX versus gemcitabine nab-paclitaxel. And then kind of thinking, perhaps the maintenance approach really wasn't the best use of a PARP inhibitor. There has been some more recent encouraging randomized phase 2 data looking at the upfront combination of a PARP inhibitor with platinum gemcitabine chemotherapy in the similar patient population, germline BRCA1/2 or PALB2 mutations. And this trial led by Eileen O'Reilly looked at upfront chemotherapy with olaparib versus chemotherapy alone. And what we saw were really, very promising response rates with the triplet, platinum gem olaparib, almost 75%, but even pretty, a reminder of the platinum sensitivity, very encouraging response rates with cisplatin gemcitabine alone, 65%. In terms of progression-free survival, they were similar, but the primary endpoint for the randomized phase 2 was overall survival. So I think that it needed some more mature follow-up to assess that. The toxicity, there were no unexpected toxicities with the addition of olaparib to platinum gemcitabine. And there was no difference in overall survival. So while the response rates were more encouraging with the combination, the addition of a PARP inhibitor to upfront chemotherapy didn't improve overall survival. That being said, I think both arms were deemed to be very promising in terms of the efficacy with respect to response rate. Again, in my practice, platinum gemcitabine is a very reasonable option, and I think if I have upfront knowledge of BRCA mutation status, I would offer this over FOLFIRINOX, given the more favorable sort of toxicity, more manageable toxicity profile. And looking ahead, there are a number of ongoing studies in the first line and second line setting trying to look at PARP inhibitors in this patient population, both in combination with chemotherapy as well as in combination with immunotherapy and PD-1 inhibitors. So I think that I think we recognize the efficacy of PARP inhibitors in this biomarker selected population of patients with DNA damage response tumor mutations. The question is how best to utilize it. And so, I look forward to kind of seeing how this data evolves. Another promising sort of molecular subset in pancreatic cancer that I wanted to end with was KRAS G12C mutations. And I think we've heard a lot of recent data on this, so it seems timely to discuss. So KRAS G12C mutations, are in pancreatic cancer. We know that, it's almost a hallmark. Over 90% of pancreatic ductal adenocarcinomas have KRAS mutations. Within them, G12C mutations are very uncommon, maybe 1 to 2%. And we recognize now that there are a class of KRAS G12C inhibitors emerging that may have a role in the treatment of our patients who have KRAS G12C mutations. This is believed to be, there's potentially a tumor agnostic lens in terms of how to look at it. And this has been explored in different disease sites, most notably lung cancer and in colorectal cancer. So at ASCO GI this year, we heard of data from adagrasib, which is a selective inhibitor of KRAS G12C mutations with the CRYSTAL-1 trial. And so this was a dose escalation study in patients with advanced KRAS G12C mutated cancers, and included a specific cohort of GI cancers, of which pancreatic cancer was the predominant subtype. So the reporting at ASCO GI focused on the GI tumors, but specifically looking at pancreatic cancer. And 12 patients within that 30 had advanced pancreatic ductal adenocarcinoma. And with adagrasib, a response rate of 50% was observed, and then disease control rate of 100%. So that no patients had progression as a best response. And the median duration of response was almost 7 months. So again, promising, early data, but certainly if we identify patients with the KRAS G12C mutation, and if you have trial at your center for one of these KRAS G12C inhibitors, I would strongly encourage that. In terms of toxicity, just to sort of sum up CRYSTAL-1, sort of typically GI-related toxicities and grade 3-4 toxicities were reported in about 21% of patients. So again, ongoing evaluation in this population. And another KRAS G12C inhibitor, which many of you may be familiar with, is Sotorasib. And this has been studied through the CodeBreak 100 trial. And so again, focusing on pancreatic cancer, there was a recent presentation looking at at Sotorasib in patients in CodeBreak 100 who had advanced pancreatic cancer with G12C mutations. And in the first report, there were 38 patients, so a larger cohort than what we saw with adagrasib with advanced pancreatic cancer. And the overall response rates were 21% in this cohort, a disease control rate of 84%, and a median progression-free survival of 4 months. So not numerically, not as sort of, I would say, meaningful as what was seen with adagrasib, but this is a larger cohort and more mature data. And adagrasib is, the only 12 patients, so not to take too much interpretation into that small subset. So, I think, but again, as is seen with G12C inhibitors in other disease sites, overall, this seems to be a tumor agnostic biomarker for response with G12C mutations. And, when we think about our patients with pancreatic cancer, recognizing that our options are limited and we still primarily focus on cytotoxic chemotherapies, there's been a huge effort to try to say, well, should we be, sequencing all these patients to look for actionable mutations? And it's believed that, through sequencing, there may be potentially actionable molecular biomarkers identified in about 25% of patients with pancreatic cancer. A big part of that, including the ones we've talked about, which are BRCA and PALB2 related. It's not easy to find and match an actionable marker, but it may improve overall survival. So this was data published from about 2 years ago that looked at a sequence of patients, over 1,000 patients, who all underwent molecular profiling with next-gen sequencing. They had outcome data for 677 patients. And again, about a quarter of them had actionable findings on their sequencing. And only about a third of those patients were able to receive molecularly matched therapy. So the challenge is not only finding the mutation, but also matching to a potentially available therapy, whether it's on trial preferably or potentially off-label. And so when they kind of looked at the outcomes for those patients who had actionable findings and were able to be matched to a therapy, which in this entire cohort of 677 patients was about 6.8%. The median overall survival was demonstrated to be much more favorable, so approaching almost 3 years, in the absence of being able to either find an actionable mutation or, if you find one and can't match it. So, I think the landscape of pancreatic cancer from a fundamental standard of care perspective still remains frontline chemotherapy for our patients, whether it's FOLFIRINOX or gemcitabine nab-paclitaxel, or again, cisgem if you have known BRCA mutation status to exploit the platinum sensitivity. I think most of the recent randomized trials that have been trying to focus on current first-line chemotherapy, specifically gem nab-paclitaxel or FOLFIRINOX, with a novel agent, either targeting a novel pathway or the tumor microenvironment in stroma, have been disappointing. But, there seems to be some promise within more defined subsets of patients. So standard biomarker testing, in my opinion, should include mismatch repair testing and BRCA1/2 mutations, and KRAS G12C inhibitors do appear to be a promising target in pancreatic ductal adenocarcinoma. I think there's still more data to come, but while a small group of patients, this may offer a meaningful benefit for those patients. So I think my 30 minutes are up. I thank you very much, and I look forward to the discussion and cases.
Thank you, Dr. Sharlene, for that insightful talk. I will hand over the stage to Dr. Vishwanath to conduct the panel discussion.
Yeah. Thank you, Dr. Santosh. So thank you, Dr. Gill, for that wonderful presentation on advanced pancreatic cancer. Switching gears, we'll move on to the case capsule presentations by two of our fellows. We'll start with Dr. Rajat Govind from JIPMER. In the interest of time, I would request both the presenters to make it very brief so we can maximize the discussion. And we also have Dr. Anant Ramaswamy, who will be part of the panel discussion. Over to you, Dr. Rajat. Dr. Rajat, you're there?
Yes, sir. Yes, I'm just sharing my.
Okay, as Dr. Rajat is, okay, we'll just wait for.
Are you able to see my presentation, sir, on the screen?
No, we're not.
There are a couple of questions in the chat box, Dr. Vishwanath. Do you want to take them?
We can start with that. So I think Dr. Santosh has a question. Okay. If a patient has mucinous type of pancreatic cancer, will the treatment change as compared to other histological subtypes? Dr. Gill, do you want to take this question?
So, no, I don't think we have any data to suggest that histology is, it may have prognostic value. I mean, I think they behave differently, but from a chemotherapy perspective, I would still offer them frontline FOLFIRINOX chemotherapy if they're eligible for treatment.
Okay, perfect. And another question from Dr. Santosh. Would you re-challenge FOLFIRINOX or gem-based chemo if the patient has a good performance status with first-line use? Or if used in the adjuvant setting, would you re-challenge?
Oh, yeah. So that, this was obviously, as FOLFIRINOX emerged as the adjuvant standard, this was a question. I think we typically would say, if the disease-free interval is longer than 6 months, then I would rechallenge. I think anything shorter than that, I would opt to switch and offer them gemcitabine nab-paclitaxel. It's kind of a rule that we've all kind of, I think, adopted in this setting. But yeah, I'm influenced by their previous tolerability and how long that disease-free interval is.
Okay. So Dr. Rajat, you're there, or we can start with the second case. Dr. Lakshma Reddy, are you ready with your case?
I request to start the second case. I'm just trying to
Sure.
get through the
Dr.
second.
Lakshma, you can start with your case.
Okay, sir.
In the meantime, we have one more question, Dr. Gill. Like in ovarian cancer, any evidence to use PARP inhibitors in BRCA negative pancreatic cancer? That's an interesting question.
Yeah, so to my knowledge, no. I think there is some question about whether when you combine with as an immune priming effect, whether there would be some value irrespective of BRCA status, but predominantly most of these studies have been focused on patients with known, I should say DNA damage response related mutations, not just exclusively BRCA. I don't know, Dr. Ramaswamy, if your opinion is the same.
Yeah, totally agree with that. Considering I think a lot of the benefit from the PARP inhibitors is a combination of platinum sensitivity and the drug. So I think, as you rightly said, they have a couple of trials combining, I think, pembrolizumab with one of these, but I think it's ongoing in very early stage. There's nothing prospective or even well-quoted retrospective literature to suggest the same.
I have one more question to Dr. Sharlene and Dr. Anant Ramaswamy. In all these patients who are running out of chemotherapy options, do you try to do the off-label therapy with doing the NGS if their performance status is still good?
Maybe I can take it. I practice in a publicly funded system, right? So I think the opportunity to test patients, to profile them, should be very early. Pancreatic cancer is difficult. We have a lot of attrition across lines of therapy. Patients decompensate very quickly. And so the opportunity for me to match them to an actionable target is through a trial. So I try to identify that as early as possible. I think by the time my patients will come to progress on first line and for sure second line, they may not be trial eligible. I have not prescribed off-label therapies, perhaps with the exception of immunotherapy in deficient mismatch repair disease, things that have a demonstrated tumor agnostic approach. But that's, it's also influenced by my practice environment. And Dr. Ramaswamy, what's your practice in Mumbai?
Completely agree with that. By the time a patient comes to second line itself is tough. And beyond that is just very rare. I can recollect on my fingertips the number whom I've given an mTOR inhibitor purely based on a NGS, but one, getting the gene to a target in pancreas, I think still a new close. Yeah.
So can we start with the case presentation? Dr. Lakshma Reddy, you can start. Be precise and
quick. Good evening, everyone. I'm Dr. Lakshma. I'm resident in Tata Memorial Hospital, Mumbai. So here is a case where a 67-year-old gentleman from Maharashtra with nil comorbidities and any addictions. And he has family history of carcinoma pancreas in elder brother who expired at the age of 50 years. He presented with complaints of vomiting, loss of appetite, and jaundice for 2 months. He was evaluated for the same. His total bilirubin was found to be 13. CA99 was elevated, 697 units, and for which of obstructive jaundice he underwent stenting. Intrahepatic biliary radical dilatation was noted. Genetic testing was done as there was positive family history. BRCA1 was positive. CT was done, which was showing iso to hypoattenuating ill-defined lesion involving the head of the pancreas. The pancreatic duct was dilated with maximum ductal diameter of 8.1 millimeter, and there is more than 180 degrees soft tissue contact around the celiac trunk and more than 180 degrees soft tissue contact around the common hepatic artery, and focal vessel narrowing and contact irregularity was seen, and gastroduodenal artery was also involved. There is more than 180 degrees soft tissue contact around the portal vein at its proximal part. Bilobar pneumopilia was seen. So these are the images where we can see this stenting with arterial and venous encasement, the mass encasing both the arteries and the veins.
Yeah, go ahead.
Then patient was enrolled in an AFPAC study that was ongoing at TMH. Patient was started on treatment with FOLFIRINOX with losartan. Post 8 cycles, patient had significant clinical response, and there was log fall in CA99. Patient tolerated pretty well. His PS was preserved. The only toxicities he had was grade 2 neuropathy, and there was no neuropathy. CT was done, response evaluation CT was done, which was stable disease. So how to go ahead? Our next is the options we have is, which I could think of was, there are another 4 more cycles because patient had very much acceptable toxicities and his PS was preserved. Maintenance with PARP inhibitors in view of germline BRCA mutation, or to the giving radiation to the residual locally advanced pancreatic mass.
Yeah. Do you want to take the question, Dr. Gill, and then we can go on with Dr. Ramaswamy for the next question.
Yeah, so you know, it's a great case. I think that it highlights a few, you know, observations that we all are challenged with kind of, you know, a non-metastatic but advanced pancreatic cancer. And one of them is that, you know, typically seeing response in the primary tumor is it's uncommon. Like a lot of times you'll see for patients with metastatic disease, we can see responses in their soft tissue, like visceral mets, you know, liver, lung, we'll see regression. But the primary tumor, it's uncommon for me to see a response, and we know that they have sensitive disease because their metastatic disease is responding, and so that makes it really hard in this space. And so we recognize that converting patients from unresectability to resectability is a bit of a miracle. I think that I discussed the POLO data. I'm not enthusiastic about maintenance PARP inhibitors for the reasons I sort of talked about, you know, especially in a patient who's tolerating chemotherapy well. And, you know, again, in the absence of a survival benefit, I'm not sure in which circumstance. I still haven't found a circumstance in which I would use it. I think there may be an opportunity to de-escalate the chemotherapy to minimize sort of treatment failure because of toxicity. So potentially going, you know, to FOLFOX if there was a concern about sort of toxicity, but wanting to keep in the platinum. Whether or not to radiate, I think in our group, we typically will present these cases at MDT. A lot of our rad-oncs are very much driven by symptoms. So they're like, if it's asymptomatic and they're getting a good response to chemotherapy, then the preference would be to continue. I think in this case, I would probably offer systemic therapy for longer, especially, you know, maybe with some modification to improve the tolerability.
Dr. Ramaswamy, what are your thoughts, and what are your thoughts about radiation to the residual mass?
Almost never do we consider, you know, any kind of long course anymore. We've almost stopped giving long course chemoradiation in pancreatic cancers, and I think that holds true across the world. We are giving a lot of SBRT to a lot of our patients with borderline resectable and locally advanced, but this is frankly unresectable disease because of the GDA and CA involvement. So rarely we do give SBRT in the small hope that, you know, we can achieve an R0 resection if we have good systemic control for maybe 6-8 months. So, you know, SBRT is something we do a lot, and that's something we'd consider. I agree with Dr. Sharlene that, you know, PARP inhibitors, you know, iffy. I would continue FOLFIRI or capecitabine based on the patient's choice. But yes, I would consider, continue some kind of systemic therapy. I tend to go with FOLFIRI because the oxaliplatin-induced neuropathy is a problem by 4 months. But some kind of systemic is what we would do. Yeah.
Dr. Gill, in the metastatic setting, we don't have a direct comparison between FOLFIRINOX and gem-nab-paclitaxel. And this gentleman is 67-year-old. Would you have considered gem plus nab-paclitaxel in this kind of setting rather than FOLFIRINOX?
Yeah, I have to say my first line preference is still FOLFIRINOX in someone who is good performance status and would be able to tolerate it. I think there have been a lot of sort of reviews trying to kind of, or sort of network meta-analyses trying to compare and suggest that maybe if in the similar patient population, the efficacy is likely very comparable. I think in this case, because of the BRCA mutation, I would want a platinum for sure. So I wouldn't go for gem-nab-paclitaxel. But in general, in all comers, my first question is, can I give them FOLFIRINOX? And if I'm kind of hesitant or the patient is hesitant, I'll go to gem-nab-paclitaxel.
And also, you did mention that you're not very keen on giving PARP inhibitors, but one of the criticism about the POLO trial is that the other arm was placebo, and there was also crossover. So, what are your thoughts about this?
So, I think that I think the placebo really doesn't represent a standard of care. Like you could argue that there should have been some ongoing systemic treatment. As was discussed earlier, maybe even the option of comparing to maintenance capecitabine would have been a better comparator. And then, certainly with the crossover, that may mitigate the overall survival benefit. But in my mind, if the question is chemo, and then you cross over to a PARP inhibitor at progression versus using a PARP inhibitor as maintenance in patients with responsive disease, and you get the same overall survival, I would probably favor sequencing it. I think that I still think that in this selected population with BRCA positive disease, that the platinum sensitivity, trying to exploit that as best as we can is really important.
Yeah, that's great. Dr. Ramaswamy, we have a question in the chat box. Can nanoliposomal irinotecan with 5-FU-leucovorin be considered as a second line after FOLFIRINOX in metastatic pancreatic cancer?
I think the logical answer is no. I mean, it would just make sense not to use the same thing once you've progressed on the same drugs, right? Essentially the same drugs. And so you would, since you have a sequence of 5-FU followed by gemcitabine based versus gemcitabine based by 5-FU based, I think that would be the logical thing to consider. Napoli, of course, was in the gemcitabine era, so it is one of the approved second line indications, but does not make logical sense to use the same. Yeah.
So do we have the other case present, Dr. Rajat? Are you able to present it now? Okay, perfect. So this is switching gears again. It's locally advanced now. So we have 10 more minutes. We'll try to get some discussion out of this. You can go ahead, Dr. Rajat.
Yes, sir. So moving on to this case, we have a 37-year-old lady who had presented to us in the month of November last year with obstructive jaundice for the last 3 months. She was also a diabetic. And at presentation, she had an ECOG performance status of 1. She had jaundice without any palpable mass or any supraclavicular lymph node. And on evaluation, she had an obstructive pattern of jaundice with serum bilirubin of 12, and which she required ERCP and CBD stenting, biliary decompression, which was done on 14th of December. And with that, there was a decline in the serum bilirubin just before thinking of further therapy. The bilirubin, the last available bilirubin was 4. CA 19.9 at baseline was 0.8. And on imaging, which was done later on, was suggestive of a head of pancreatic lesion around 4 centimeters with bilobar IHBRD. And this lesion was seen to have abutting the superior mesenteric vein for more than 180-degree contact with without any evidence of any intraluminal extension or any free fluid. However, there was some evidence of fat stranding, which was seen around the pancreato-duodenal groove and was also seen abutting the second part of the duodenum. And thankfully, there was no other sites of distant metastasis. So what we had was a 37-year-old lady who was a diabetic with adenocarcinoma head of the pancreas, which was proven by EOS-guided by the FNSU of the head of the pancreatic lesion, and which was borderline resectable considering the more than 180-degree contact with the SMV with a good performance status at presentation. So as we had discussed later on, that the intent of therapy in our minds were clear to convert this borderline resectable to a more resectable locally advanced pancreatic cancer. The options that we had were neoadjuvant chemotherapy versus maybe sequential addition of chemoradiation like SBRT to for upfront chemotherapy, neoadjuvant chemotherapy. And the points of discussion was the choice of a neoadjuvant chemotherapy or upfront chemoradiation in such a setting. Before we move on to the discussions, I'll just put a few more inputs that we had actually started this patient on FOLFIRINOX since the performance status was 1 and she was the other parameters were normal. So we delivered this first cycle in the month of December. And unfortunately, the patient did develop grade 3 toxicity to this first cycle of neoadjuvant chemotherapy. And we had lost her for about a couple of weeks for the interim when we wanted to see her. And unfortunately, a month later, she came to us with new liver lesions without any clinical worsening though. And so she had basically a progressive disease. So this was, retrospectively thinking, is there any other points of discussion is what we were thinking.
Yeah. So I think Dr. Rajat has brought out the $1 million question, neoadjuvant chemotherapy versus neoadjuvant chemotherapy with radiation. So Dr. Gill, would you like to take this question?
So, I think in patients, with where the goal is conversion, you want to offer the treatment that's going to give you the maximal opportunity for, response and downstaging. We would still start with systemic therapy first. So, and I think currently FOLFIRINOX represents the preferred regimen in terms of response rates. You were asking earlier about gem-nab-paclitaxel versus FOLFIRINOX, but certainly we know kind of response rates are better with FOLFIRINOX. Gem-nab, we think 20 to 25%, FOLFIRINOX 35 to 40%. So, and then we would restage them after 3 months of therapy. And then there would be a discussion about whether or not you would offer, and in this case, again, I would agree with Dr. Ramaswamy that the question would be SBRT to try to evoke the maximal response in patients with borderline resectable disease. I would say that, what happened in this unfortunate case with this young woman, speaks to, the fact that, pancreatic cancer is a systemic disease. And I think that, her biology declared itself early. I don't think this is something that could have been mitigated. This was going to happen. But I think starting with upfront systemic therapy makes a lot of sense. And it's kind of why even in patients with resectable disease now, the current trials are looking at neoadjuvant FOLFIRINOX chemotherapy in that setting, because we recognize the risk of systemic failure is high.
Dr. Ramaswamy, now we have the SWOG data. I know Dr. Gill is talking about FOLFIRINOX. We have the SWOG trial, which has shown almost similar response rate, but none of them met who is the winner was the endpoint. And I think neither of them reached the 58% overall survival at the end of 2 years. But if you see, both were quite comparable. And in Indian setup, patients little frail compared to Caucasians. What do you think? Would you use gem-nab-paclitaxel in this setting? In the borderline?
So I personally am a big fan of hit it first hard, and my first instinct is to go with FOLFIRINOX because it has the best available data. We actually have recently submitted a match pair analysis of this of around 400 patients, and much to my surprise, we found no difference in locally advanced and metastatic pancreatic cancers. It's been accepted for publication. So I am rethinking my philosophy, and it's essentially a philosophy. There's no direct comparison, right? But irrespective of the Indian setting and all that, the kind of responses and relief in pain that you see with pancreatic cancers with FOLFIRINOX, I haven't seen that much or to that degree with gem-nab-paclitaxel. So my this one would be FOLFIRINOX, and then take it as it comes. Now, this patient, unfortunately, even for a pancreatic cancer, is very rapid progression. We're used to seeing rapid progression, but this is a little, it's unfortunately quick. Yeah.
Yeah.
Yeah, that's fair enough. So Dr. Gill, you also mentioned about GemCis. say this, considering that this case would have been a BRCA mutated patient, would you consider this as a different disease and okay, FOLFIRINOX, or would you consider GemCis in this kind of scenario?
Yeah, I think, I have to admit I know it's randomized phase 2 data only, but Eileen O'Reilly's data in the Velapro trial with the sort of 65% response rate with GemCis, I think it's more tolerable than FOLFIRINOX. It's also not fun, but more tolerable than FOLFIRINOX. If it was known, I think that would very much be sort of an acceptable option, a preferred option. Anything like, again, it has to be platinum based. And I think, again, it's why it's helpful for us to have an infrastructure where these can be tested up front, rather than what's happening now usually is at the time patients are failing their line of therapy, then we start to think about what to offer next. And I agree with Dr. Ramaswamy that this was, even for pancreatic cancer, very rapid progression. And I think the biology of disease in our younger patients is different. And we see that with a lot of other malignancies. I only treat GI. I just know that early onset cancers behave differently and typically progress more quickly.
And this was actually my next question. Would you actually do upfront NGS to both of you? Upfront NGS for all this actionable mutations like NTRK and HER2, MSI? I know pembrolizumab had a very minimal PFS benefit, but would you do NGS upfront for all these patients?
Maybe I'll let Dr. Ramaswamy go first.
The data by Pishevan et al., only 6.8% of patients in the, I think this was a US setting, if I'm not wrong, were matched to a drug. Try matching a drug for a patient in India and pancreatic cancers. It's very difficult, so I am yet to be convinced on the use of NGS in pancreatic cancers. Definitely in my setting, I would do an MSI and a BRCA because that appears worthwhile in time. Maybe, look for KRAS as well. But NGS upfront, I might change my mind later, but not now.
Yeah. I have to agree. The challenge of matching a patient is a huge one. Like you look at that Pishevan data, but the proportion of patients who had actionable findings and were not matched, I think that's just torture for a patient to say, well, there's something that we maybe could do, but we can't access it or don't have a trial. I do it, again, I mentioned in the context of, we have two molecularly driven basket studies at our institution, and we can funnel patients into potential arms. And it's not with a promise that they would be able to get on, there will be an arm, but I mentioned before, I've never really used it as an off-label approach. It's just not tenable in practice even in Canada. So,
in fact, Dr. Milind Chawli from MD Anderson, he gave a talk in this ISMPO, recently concluded ISMPO con, and he did mention about this NTRK inhibitors. Patient was on ventilator, dramatic response. It's like winning a lottery. So he was talking about the patient just came out of the ventilator. So there was so much of dramatic response with NTRK inhibitors. Yeah, but like you said,
I think in pancreatic, just one comment to that, just so in pancreatic cancer, so RAS mutations and NTRK are typically mutually exclusive. So if I had a patient who is the 10% with RAS wild type, let's say I did a panel, RAS wild type disease, or you could do KRAS testing at your center. A lot of people do it for colorectal anyway. Then maybe I would look for other things because those are different. So you can have a tiered, like a gated approach to your molecular testing as well.
So just to conclude with these last three questions in the panel, in the chat box, are tests available to look at the expression of DNA damage response genes, Dr. Ramaswamy?
So I think she's talking about the Myriad diagnostics. I've never used it. So, the BRCA-NES, no, I have no idea. It's not available in India, I know, but maybe Dr. Sharlene can,
Yeah. So it's also not available in Canada. We will do like a germline panel for all our patients. And unless it's part of a research protocol, we have a trial called a research study called PanGen, where we're doing sequencing for patients with pancreatic cancer, but I've never used a commercial assay for that.
Next question is about neoadjuvant CT chemotherapy with radiation with immunotherapy. Can it help improve resectability in borderline pancreatic cancer? So
I think till date, the best biomarker for immunotherapy is a deficient MMR status. Without that, I'm not going to try it unless it's in a trial. In a trial, also, I suspect you might not get great responses, but yeah.
I did see something on NCCN about the tumor mutational burden more than 10 base pair. So what do you think about that?
I think that I was surprised, honestly, by that FDA indication because I think the data is not that strong, and we also know that the tumor TMB threshold of responsiveness to immunotherapy may be different for different disease sites as well, even though you think it's a tumor agnostic response. So I've never used that as an indication for.
So it's not just in pancreatic cancers. I think it's slinked its way into gastric cancers as well. The TMB in the guidelines. I completely agree with Dr. Sharlene. Not convinced. Yeah.
And this question is to Dr. Gill. Would PRIOPANC 2 and the new alliance trial, the pre-op FOLFIRINOX with adjuvant FOLFIRINOX, do you think it's going to change the scenario in this neoadjuvant setting?
I think a lot of people, especially our surgeons, have already drunk the Kool-Aid for neoadjuvant therapy in resectable disease. So but we at the end of the day, we may have a good guess or a good hunch or a good feel about it, but we need the data to really change that standard of care. So I believe it will.
And one last question to Dr. Ramaswamy from the question and answer box. Definitive indications for neoadjuvant chemoradiation and borderline resectable pancreatic cancer. I think this has been answered, but you'd like to take this question, Dr. Ramaswamy?
All patients with borderline resectable pancreatic cancer can get either neoadjuvant chemoradiation or neoadjuvant chemo as the current evidence stands. What I would, with PRIOPANC, the only rider to that is that I would advise not to consider long course chemoradiation. I think the time is gone. If you want to give radiation, consider a shorter course with ideally FOLFIRINOX at least, but you could use either chemo or chemoradiation for your borderline resectable cancers. No patient with BRPC should be operated upfront. Yeah.
And Dr. Gill, one of the criticism of the PRIOPANC 1 was they used older regimens like gemcitabine-based regimens, not 5-fluoroquinolone-based regimen, like not FOLFIRINOX, not like the alliance. So would that?
So I think it's a valid point, right? The problem is that the current it doesn't reflect current standard of care. So I think that's why the accrual to the alliance trial is very important. We need to answer that with a contemporary regimen like FOLFIRINOX.
And the last question, is there any role for adjuvant olaparib after completion of standard adjuvant chemotherapy in resected pancreatic adenocarcinoma? I think the answer is no.
No, that's easy one.
Yes. No.
Yeah, Dr. Santosh.
But I can see where the question comes from. Like someone made the comment earlier, like we treat other disease sites like gynae, and people think about, well, what is the application in that setting, but not for pancreatic cancer. Yeah.
Okay. Thank you so much, Dr. Gill and Dr. Ramaswamy. It was a very interesting discussion. And thank you, Dr. Rajat and Dr. Lakshma Reddy for presenting those interesting cases. Dr. Santosh, any concluding remarks from you?
Yeah, wonderful discussion. I would sign off by thanking our sponsors, Zydus and Fresenius. And I also want to thank the attendees who are logged in from various parts of the country and abroad. Thank you. Thank you, one and all.
Thank you.
Thank you.
Have a good day. Thank you. Bye-bye.